Hello, and welcome to the workshop From Worn Out to Energized, Tackling Fatigue After Transplant and CAR T Cell Therapy. My name is Steve Bauer, and I will be your moderator for this workshop. It's my pleasure to introduce today's speaker, Dr. Alexandra Muench. Dr. Muench is a clinical health psychologist at the University of Pennsylvania Perelman School of Medicine. She specializes in the treatment of sleep disturbances and fatigue in individuals with cancer. Dr. Muench developed the Penn Sleep and Cancer Clinic, where she delivers tailored behavioral interventions designed to address the unique challenges faced by cancer patients and survivors. She is a passionate educator and advocate for patient-centered care. Please join me in welcoming Dr. Muench.
Hi, thank you so much. I'm so excited to be here. I do want to make a small correction. I've recently transitioned over to Penn Medicine Princeton. So I'm still at Penn, but I'm now in their integrated clinic where I work with oncologists in an integrated setting, helping folks with all kinds of things related to cancer, including fatigue and sleep issues. So as just mentioned, we're going to talk a little bit about how we tackle fatigue. I do always like to start presentations like this in saying that we are still in the early stages of figuring out how we identify and treat cancer-related fatigue. So the research is growing, but some of this will be specific to transplant and CAR T cell therapy, but some of the research has been done in other cancers, and we're working tirelessly to try to expand this and figure out the best way to go about treating both during and after treatment. With that said, I do like to start with some background defining fatigue. So what is fatigue? And where I like to start is with the dictionary with our old friend Merriam-Webster here, which defines fatigue as a weariness or exhaustion from labor, exertion, or stress. That's our very broad definition, but what we're going to see in a minute is in the context of cancer treatment, survivorship, it's a little bit different. So what about cancer-related fatigue? So the National Comprehensive Cancer Network, also known as the NCCN, defines cancer-related fatigue as a distressing, persistent, subjective sense of physical, emotional, and/or cognitive tiredness or exhaustion related to cancer treatment that is not proportional to recent activity and it interferes with usual functioning. That's a really big mouthful, so let's break that down. So what is cancer-related fatigue? It's distressing and it can be persistent. It can affect you physically, emotionally, or cognitively, and it can result in tiredness or exhaustion. It's not proportional to recent activity. This is a big one. If we go back to our Merriam-Webster definition and we think about things like exercise or if we've had a big day, that's often proportional to the activity and the energy we expended, but cancer-related fatigue is not, which makes it distinct. And it interferes with usual functioning. Probably the biggest thing, right? It makes it hard for us to live our lives in a way that brings us joy and adds value. And this is often what I'm seeing when I'm talking to folks is that their quality of life is greatly diminished. So these are different beasts. Fatigue, right, as we know it broadly, is proportional to our activity. It can be from labor, exercise, exertion, stress. The cancer-related fatigue is vastly different beasts. It's more severe, more upsetting, more disabling, more long-lasting, and much more difficult to relieve, which we'll talk about in a little bit. So how is cancer-related fatigue, also known as CRF, experienced? There was a meta-study of 16 qualitative studies, meaning that they asked folks, how do you experience your cancer-related fatigue? And 6 overarching themes were identified. We had loss of self, embodied experience, small horizon, misrecognition, role changes, and then finally regaining one's footing. So when I think of loss of self, or when we think about it in the literature and when we talk to folks who are experiencing this, it's losing a sense of who they are. Again, coming back to role changes. If pre having cancer-related fatigue, you were able to run 5 miles, right, and that was a big part of your day and your life, not being able to do that can make you feel sad, which can increase stress, thus maintaining cancer-related fatigue. Misrecognition, so not understanding what you can and can't do. When things change so quickly, you can feel like you should be able to do these things, but it's hard. Role changes comes under this too. We talked about that. Embodied experience, right? Having these physical changes. People describe this as, their body feels heavy, and small horizon, being that your world starts to become small as you feel more limited. But there are ways to manage this where you start to feel like you're regaining your footing and come to accept that although you might have this symptom, you're able to still live a full life. So the big question everyone always asks is, how common is cancer-related fatigue? The short answer is it's very common. In one study by Ma and colleagues, they found about 52% of patients across 84 studies reported having cancer-related fatigue at some point. It is the most common side effect of cancer treatment. It can be a symptom of cancer itself, right? So when our body is sick, we start to feel fatigued. It is often rated as the most distressing. There was a paper specifically looking at CAR T cell therapy, and folks in this study, patients rated fatigue as the most common symptom and also the most long-lasting. One thing that I like to caveat here, though, is that, as I said at the beginning, this research is up and coming, and so what you'll see if you were to look at the literature, although Ma did a meta-analysis and looked at 84 studies, is that this number varies. So it could be anywhere from 20% of patients experiencing this to 95%. And the reason for this is it really depends on the type of cancer, the type of treatment, your sex or gender, other psychosocial stressors going on, other comorbidities, meaning, physical, mental. And so what we're really trying to do in the research that I'm doing is drill down on this and try to figure out, by type of cancer, by treatment, what are the risks of this symptom? Okay, so coming back to Ma's study, they looked at cancer-related fatigue in regards to severity, sex, age, and treatment. And what they found was, in their study, most people rated their cancer-related fatigue around moderately. By sex, it was females who seemed to experience a little bit more. We're looking at 39% versus 34%. Folks over the age of 65 seem to experience fatigue a little bit more than folks under the age of 65. We actually did a study that's ongoing where we're collecting as much data as we can, looking at, again, cancer-related fatigue across different diagnoses, age, sex, et cetera, and radiation treatment. And we found a similar thing, that folks over the age of 65 do seem to experience and report cancer-related fatigue more than the younger cohort. Treatment seems to matter too. This is pretty consistent across the literature. Chemo and radiation, when compared to surgery alone, seems to produce more cancer-related fatigue. But again, this is ever evolving and growing, and different types of treatments are coming on board, so we will keep evaluating. Okay, so why does cancer-related fatigue happen? It's like a needle in a haystack. There's so many things that can cause fatigue. We don't really know for sure, but we do know there's some things that can contribute. Systemic inflammation, we see this in CAR T cell therapy, anemia, depression, sleep disturbance, and we'll come back to that one because we do think that cancer impacts sleep, and subsequently it can cause daytime consequences like fatigue. Physical inactivity, higher body mass index, pain. If you have pain, that can certainly impact you, especially if it's impacting your sleep at night. Type of transplant seems to be related. So the type of stem cell transplant you get. Infection, if you're having any respiratory issues, any problems with other organs, coping strategies and expectations. So this is something we talk about with medical teams as well. Depending on what the patient's needs are, it's probably helpful to be transparent about what could happen. It doesn't mean you're going to develop these symptoms like cancer-related fatigue. However, you can, so it's important to educate the folks around what could happen. Cancer treatments, I've said this already, but depending on the treatment you get, might make you more prone to developing cancer-related fatigue. So when does cancer-related fatigue happen? So the ultimate question, I think about it a lot. We suspect that it's probably happening even before diagnosis. This is an assumption. It's hard to test, right, because I can't go back in time as much as I would like to. But anecdotally, a lot of times folks will say to me, I knew something was off because I just wasn't feeling like myself. I was feeling fatigued. I went to the doctor. So we suspect it probably happens at some point before diagnosis, and then treatment, and then oftentimes into remission. Now, in CAR T cell therapy, a lot of the studies only look up to 3 months, and fatigue still seems to be present at that time, but overall, it does seem to remit. But more work needs to be done there to determine how long fatigue is lasting into survivorship. There's other cancers like breast where the fatigue, partially due to the post-treatment drugs that people are on, can last way longer. So the jury is still out on that. Right. So in terms of how long does CRF last, there was a study done where they asked patients to rank each symptom as lasting the longest. And what they found in these folks is that most people, about 54%, more than half, reported fatigue as lasting the longest. And then they followed up with the percent of patients that said the symptom that impacted everyday life the most. And fatigue, again, was rated as the most persistent symptom, which when I saw this didn't shock me. It's often the one that people come in with, that and pain, as having the most impact and burden on their quality of life. So specific to CAR T cell therapy, there was a study done. I don't want to butcher this author's name. I've been trying to practice it, but we'll give it a go. Wizenat and colleagues in 2021 looked at different symptoms that present with CAR T cell therapy, and they found that fatigue was, again, the one that was most prevalent. Pain was also up there, but fatigue seemed to be the one that was impacting quality of life the most and lasting a bit of time. Again, the study looked out about 3 months and didn't follow up after that. So I'd be curious how folks are faring after that 3-month point. All right, so the big question, what can be done about cancer-related fatigue? Before I even get into this, I want to say we don't at this time have medication that can be given. So I typically put together with my patients what I call the fatigue package, pulled from the literature, things that you can do to take the edge off and also maybe roll it back a little bit. I use the analogy of pain, right? So if you've ever had any type of pain, typically what's recommended is you take the medication before the pain gets really bad. And so intervening on fatigue early, and sleep disturbance for that matter, although we're focusing more on fatigue here, can be prophylactic in nature, so it doesn't get too serious. And so I'm always encouraging my medical providers, consult me at the first mention of fatigue, not when it's already having a detrimental effect on someone's quality of life. Okay, so the first is patient and family education and counseling, because we don't want to forget the caregivers here. So education about fatigue, especially if undergoing fatigue-inducing treatments, radiation, chemo, the CAR T cell therapy. What is the risk of fatigue? How long might fatigue last? What can be done about it? And also in terms of expectations, how am I going to feel after treatment? Are there ways to navigate this beforehand for the caregivers as well? What can the caregivers expect for their loved one undergoing this? Also to recognize that fatigue is not necessarily a sign that treatment is not working or that the disease is progressing, right? Treatments, I just was meeting with someone before this where we identified that after chemotherapy, fatigue is the worst, and it doesn't mean that the treatment isn't working, but chemo can have an effect on your system that causes fatigue, and after a few days it can remit. So just recognizing what is a normal symptom of treatment and what might not be. Again, reiterating, fatigue, I got ahead of myself, can be a consequence of treatment. And also other things, right, that can impact nutrition consults, right, if you're having trouble eating, which is totally fair, drinking water, if there's any form, we'll get to exercise, but exercise can also be helpful. Some of that comes from the multiple sclerosis literature, but I'll get into that in a moment. All right, general strategies. So energy conservation is a big one, and I often struggle with how do we measure this? And when I say energy conservation, it's also called activity pacing. So I always like to go back to the pain literature because they've done a good job of expanding on this. So in chronic pain, they talk about activity pacing as well, because oftentimes fatigue, it's not like we're having a quote unquote bad day every day. It comes and it goes. Like I said earlier, it might be worse after treatment. So I encourage my patients to engage in this activity pacing, which means learning to manage some expectations around what you can and you can't do. So it might be you're used to, I'll go back to the running a few miles every day, and that might not be possible right now, but could you take a walk? It might not feel the same at first, right? We're all active people, but is walking helpful for now? And then maybe we can build up to running again if that's possible. So it's keeping your expectations, and also you can't see me, but think of it as a flat line versus good day where you go up, bad day where maybe you don't feel good for a couple of days, good day, bad day. It's starting to tune into what does your body need. Maybe today we do need to relax, take a bit of a nap, which I'll talk about in a little bit. And so it's starting to tune into what can I do right now, what's good for me, what feels good, and maintaining energy levels so you're not kind of crashing and burning. Now, there are apps that can be used for this, which I sometimes will recommend to my patients. There's an app, and there's no conflict of interest here, just something that I recommend, called the Visible app. It was created specifically for folks who have fatigue. It's VISIBLE. So that's an option, and it's a more engaging way it'll track your energy and say, you know what, maybe you need a rest. Maybe you can be a little bit more active today, or you can maintain a diary where you say, you know what, yesterday I helped my kid move, and then I was out all day, and I felt really bad the day before, and I didn't take any breaks. And bring that to your doctor if you're meeting with someone like me, and we can go through and say, okay, what could we have done differently to make sure you're able to maintain your energy and not have a few days where you don't feel so good. Distraction too. So when I think of distraction, not in a negative way, but once we become really focused on the symptom, which it's hard not to be, it can be all consuming. And so finding value, what are the things that maybe you've disengaged from in your life that you could bring back in? It might look different, right? Coming back to the walk, but distraction can be a powerful thing. And coming to naps. So, on our social medias and in the culture and the zeitgeist, napping has been seen as a no-no. I actually don't feel that way, and the literature tends to agree in the context of illness and treatment and things like CAR T cell. And so what I try to do for my patients is, let's say we have treatment and we're not feeling so good, let's put some boundaries around that nap. So daytime naps, 30 minutes or less, in bed, because we want the bed to be paired with sleepiness, right? We don't want to be spending all our time in bed. That can lead to wakefulness in the bedroom before 3 p.m. And one thing that I love is something I heard on a talk from a military psychologist. It's called a nappuccino. So if you are typical coffee drinker, I wouldn't encourage inserting caffeine if you don't drink coffee. But if you drink coffee, have a small cup of coffee before you lay down for your nap. And the reason for that is you get a double whammy of rest. So you get the rest and restoration from the nap, and then by the time you wake up 30 minutes later, you have the coffee hitting your bloodstream, and that can help you feel a little bit better if you feel you need it. Another caveat about napping, it doesn't always mean falling asleep. It could just be taking a moment, taking 30 minutes to yourself if you have it, even 15, 10, 5, to rest and then come back to your day. Okay. All right, let's talk about pharmacologic interventions, because this is a question I get asked a lot. We don't really have any that work super well. There's some evidence that psychostimulants like modafinil can take the edge off, and that's something to talk about with your doctor, and corticosteroids. But there's some thought that the reason they don't work really well is that the fatigue we're experiencing at a brain level, at a neurobiological level, the psychostimulants aren't hitting the parts of the brain they would need to cause relief, but they can take the edge off. Again, I have seen docs prescribe modafinil. There's some literature to support it. In terms of effect size, which is the size of an effect, they're moderate, but it depends on you and the treatment, and oftentimes the coffee that I just recommended will have the same effect. And I will say there's a little bit of hope potentially coming in terms of medication. I know I'm a psychologist, but I'm also a believer that especially in the context of acute treatment right after therapy, medications would do a world of good. And there's some medications that could potentially be on the market soon that might be helpful. So stay tuned for that. Okay, non-pharmacologic intervention. So we've talked a little bit about physical activity. This is kind of a big one. A lot of this has come from the multiple sclerosis literature, and I don't want to equate the two because we don't really know if across disease states the fatigue is similar or different, especially mechanistically speaking. However, there is some literature to suggest, even in cancer, that physical activity can be helpful, and we'll talk more about that in some detail. Psychosocial interventions, like coming to talk to someone like me so we can dive deeper in on your fatigue and anything that might be causing it. And bright light therapy, another really good one, especially if you live in a place that's dark for a few months out of the year. I highly recommend, and we'll go more into that in a moment. Okay, so physical activity. So there was a study done, a meta-analysis, it looked at 72 studies across over 5,000 patients in active treatment or follow-up. They found a moderate effect, which means probably around 0.5 of exercise, reducing cancer-related fatigue compared to control group. This is important. Exercise type does not matter, and the more tailored, the better. When I'm meeting with patients, I will say even a little bit helps. If you're not, if you're really feeling fatigued, I just said this to someone today, can we get up and just walk around the living room? Just something to get your body moving. Or if you can have physical therapy or other exercise program. Again, this isn't going to take away all of the fatigue. I don't want to overstate this, but it's just getting your blood flowing and moving if you're feeling up to it. Another area of research is bright light therapy. It's historically commonly been used to treat seasonal affective disorder. One thing we're seeing in the literature is that cancer and cancer treatment seem to have an effect on the circadian system. We're still trying to tease this apart. However, what we think happens is we have a main clock in our brains called the suprachiasmatic nucleus, and it stands to reason that our cells have clocks too, and tumor cells probably have clocks. And so we think that bright light therapy is effective. We've seen it be effective for cancer-related fatigue. We think this is because it's re-regulating your sleep system, your circadian system. And so what we're seeing is that systematic exposure to bright light, they normalize these rhythms, and that there's pilot studies, some by Sonia and Coley Israel, that show it may prevent, so remember prophylactically, trying to prevent the fatigue and or treat fatigue in patients with cancer and survivors. I often recommend that my patients get a Happy Light or one of the lights on Amazon. They're the size of an iPad. They're relatively inexpensive, and I'll go into how to use them. So what does it look like? So 30 minutes each morning. It's important to use it in the morning, not in the afternoon or night, because light can impact your sleep. 4 to 8 weeks. Bright light, broad spectrum. Again, you can find these on Amazon. It's a small lamp. The ones on Amazon look a little bit bigger. They're the size, again, of an iPad. And you keep it about a 45-degree angle, arm's length away. There's also light goggles. The only caveat with light goggles is if you're sensitive to light and you have like migraines or anything going on in the brain, we don't recommend that. They're also often quite a bit more expensive than the lamps. But light is important. In general, for us as humans, light is why seasonal affective disorder exists for those of us in the Northeast and other areas where it's dark. Okay, so the bottom line about fatigue is it's real. It's different from regular fatigue. It's common, severe, impactful, and long-lasting. The causes and mechanisms are unknown, although we suspect. We probably understand why it's happening, but there's more research to be done. But there are a variety of tools to help treat or help with the management of cancer-related fatigue. In specific to CAR T cell, again, that's kind of being unpacked. The literature is new. A lot of this research has been done in breast and prostate, but we're expanding, we're moving. I'm doing some of this work to try to figure out how it looks different across disease states and with treatment, so stay tuned for that. All right. So let's talk a little bit about CBT for insomnia. I focus a lot on fatigue, but I don't want to miss out on the sleep health component of it. So CBT for insomnia was developed about 25, 30 years ago. If you've heard of cognitive behavioral therapy in general, this is a little bit different. It's really more behaviorally focused. It's typically 6 to 8 sessions. It's super robust. I always say, I'd love to say it works for 100% of people, but I can't say that, but it works for a lot of people, and it works in cancer. We're running some trials on this now, and I will share those slides with you in a few minutes. So what it does is we ask folks to keep a sleep diary. And with that data, we set a standard schedule where you have a bedtime and a wake time. And in cancer, the wake time is very important, coming back to that circadian system. Circadian is our alerting signal. It wakes us up in the morning. And so if we want to have a strong circadian system, especially if we suspect that cancer is dysregulating that, it stands to reason you want to try to get up at the same time every day. And so CBTI works on both your sleep system, which puts you to bed at night and hopefully keeps you asleep till you wake up in the morning, and your circadian system by giving you a schedule and ensuring that you're tired enough to go to sleep and that you're able to wake up at the same time every day. Right now, we don't have enough CBTI providers. I had I did. It's now being run by somebody else because I've come over to Penn Princeton. But at Penn, we have the Sleep and Cancer Clinic. If you're in the Pennsylvania area, that exists. And if you have an oncologist here, they should know about it and can refer you over. However, there are CBTI providers throughout the country. If you search CBTI providers, and there's one in your area. A lot of them offer telehealth. We're still growing this field. The broader field called behavioral sleep medicine is relatively new when compared to other fields in medicine. The first paper was in 1987, so we've grown quite a bit, but we're still trying to train people up. But again, if you Google CBT for insomnia, that's CBT for insomnia provider, a provider directory should pop up. And hopefully you can find someone in your area or somebody who provides telehealth services. All right. Okay, so the Sleep and Cancer Clinic that I developed was a collaboration with the Department of Psychiatry. It began in February of 2024. I mainly provided CBT for insomnia and cancer-related fatigue management to patients diagnosed with cancer and cancer survivors. So these were patients across the diagnostic spectrum. We assessed treatment outcomes with what we call the Insomnia Severity Index, the Brief Fatigue Inventory, and we also looked at something called sleep efficiency, which is a number we calculate by how much time people are spending in bed and how much time folks are sleeping. I also provided information and education to oncology teams on how to identify insomnia and fatigue in the context of cancer, going back to our conversation earlier around how educating providers is important, right, on how to identify these things so patients can get referred appropriately. And again, providers were encouraged to refer patients with insomnia and or cancer-related fatigue. And this was pretty much a telehealth clinic. I did this because at Penn, especially downtown, we have folks coming from all over the place. And so I wanted this treatment to be as accessible as possible. And folks also could come in person, but most people opted for telehealth. And again, sessions were conducted via telehealth. All right, so I looked at REACH, which is defined as the number of patients referred divided by the number of patients scheduled for an intake, and retention defined as the number of patients who completed treatment divided by the total number of scheduled patients. And what, again, this was just me here, but from March 2024 to February 2025, we had 78 patients referred. We had 44 complete intake. So we reached over half of the people, about 56%. And in terms of who we retained, the number of patients who completed treatment was 26, and the total number of scheduled patients was 44. So we were able to retain about, or I was able to retain about 60% of folks. And some of the reasons for loss to follow-up was, we had some folks pass away. We had some folks who went back into treatment who felt like it was, a lot to do this at this time, which is totally fair. But overall, what we're seeing here coming back to treatment of fatigue and insomnia in the context of cancer is that we are able to reach and retain folks and help them with their symptoms. All right. So of the 44 patients who completed treatment, I included 13 subjects in our analysis. So again, patients who were not included did not have pre to post data. So I was collecting those measures, or they received fatigue management specifically, not insomnia and fatigue management. And so the subsequent slides include data on their demographics, pre-post insomnia data, fatigue data, and their sleep efficiency. So we had primarily females, about 85% of our sample. The majority of those folks were white. The mean age was about 62, with a standard deviation of 14.7. And what we see here in this graph is that the ISI is the insomnia measure. So 14 is moderate insomnia. At post-treatment, we were able to decrease their insomnia to mild at 6.2, which was about a 56% change, and the effect size of 3 is a big effect. The brief fatigue inventory, anything above 4 is considered moderate to severe fatigue, and after treatment, I was able to get them down to 2, which is great. That's below the significant threshold with a percent change of 50%. And sleep efficiency, so we're often aiming in sleep efficiency for folks to be above 85%. On average, people came in around 76%, and at post-treatment, we had them up almost at 92 with a percent change of 21%. So although this is a small sample, I just wanted you all to see the effect that CBT for insomnia can have, not only on sleep, but also on fatigue. And we think this has something to do with our ability to consolidate sleep and its effect on the daytime. So here's just a graph representing our pre to post change in insomnia. And here's our fatigue pre to post change. And our sleep efficiency went up quite a bit. So another study that we're doing, this is in breast, We are looking at the effects of CBT for insomnia on insomnia, of course, but also fatigue. So when I was in my fellowship, I was thinking a lot about the studies I was reading, and that I noticed they were reporting fatigue as a secondary outcome, and they were doing CBT for insomnia, right? So I said it's about 6 to 8 sessions. The manual is 8 sessions, but the effects weren't that great. And I thought to myself, well, maybe it's because we're giving the same amount of sessions that we would give to somebody who doesn't have cancer or hasn't survived cancer, that we would give to a healthy person, right? Somebody who hasn't had a diagnosis. And maybe we need to increase the number of sessions to see more of an effect on fatigue. If we are hypothesizing that part of fatigue is related to disrupted sleep and circadian issues in the circadian system, it stands to reason that maybe we need more treatment to regulate this. So this is what we did. This is from my fellowship, and we're testing this now in a larger sample. This was about 13 people. We gave the insomnia severity index, which is on the left, and the FACIT, which is another type of fatigue measure. And not surprisingly, so if you look at here on the X, you see 1, 2, 3, that's pre-treatment at 1, post-treatment at 2, and follow-up at 3 months at 3, and same on the FACIT. Not surprisingly, we saw a treatment effect with the ISI because CBTI works. It's super robust, and we were able to improve sleep. That wasn't that shocking to me. So they went from like moderate to severe insomnia to not really having any insomnia at all, what was more interesting to me on the FACIT. So the FACIT is reverse scored. So if you're around a 30, that's moderate to severe fatigue. Once you get up around 40, that's minimal fatigue. With that, the folks in the number of sessions, so we had 4 session, 8 session, which was a normal amount of treatment, and then we had 10 session, 12 session, which was considered higher dose. We saw quite an effect. Now, we can't make a lot of claims because this is a small sample, but the percent change was about 69%, and remittance in fatigue. So that got me curious, and so we're doing this again in breast, but we plan to write a larger grant where we're going to expand this to other cancers and see if we got the same effect across different diagnoses. So we think that consolidating sleep and fixing sleep health seems to have an effect on fatigue. It doesn't explain all of what's going on with fatigue, as I said earlier, but CBTI does seem to help a little bit. So sleep is important here. And just as another little note, historically, the literature said that sleep and fatigue are distinct entities, and fixing one will not fix the other, but we're starting to show that that's probably not true. All right, so future directions. So expansion of services, as I said earlier, we need to increase the accessibility of services, including to underserved populations. Research and innovation, we need more research on novel treatment approaches to CRF, especially in transplant and CAR T. We don't have enough, very minimal. Training and education, enhancing provider training in behavioral sleep medicine, which is our umbrella over the work that I'm doing to improve integration in oncology care, and assessing the sustained benefits of treatment and exploring more of the role of sleep interventions in cancer survivorship and recurrence prevention. I often wonder if fatigue is an early symptom of cancer. What if we were able to identify that? Could we diagnose sooner? But that's a different talk for a different day. And I just want to say thank you to my collaborators, Dr. Gary Friedman in radiation oncology at Penn, and Dr. Michael Perlis in behavioral sleep medicine at Penn as well, and my administrator and research coordinator, Desiree and Mark, and really all of Perlman Oncology and all of the amazing patients I've been fortunate enough to work with and continue to work with. And I will give my email if you have questions or comments or questions about receiving CBT for insomnia. I'm always happy to hear from attendees. Thank you, and here are my references. Thank you so much.
Thank you, Dr. Muench, for this excellent presentation. We will now get to some questions and answers. If you have a question for Dr. Muench, please type it into the chat box on the left side of the screen. We will answer as many questions as possible. Our first question is, my spouse is 5 months post-transplant and naps a lot during the day. Should I wake him up and get him to talk, or should I let him sleep when he wants?
Yeah, that's it. That's a great question. So I would say going back to smart napping, something that I named it, is it's probably best, he's 5 months post-treatment. Again, a lot of the data goes out 3 months. But I would say probably trying to have some boundaries around naps. I'm not sure if he's not sleeping well at night, but the concern always with napping during the day is it's going to make it hard for you to sleep at night. So if his sleep isn't impacted, I would say, you can let him nap, but if his sleep is being impacted or you feel like maybe it's impacting his mood, it might be worth encouraging him to have some boundaries around the naps. So again, I try to encourage patients to limit naps to before 3 p.m. so we're not bleeding into the sleep, its impact on sleep, excuse me, and limiting naps to around 30 minutes in bed with an alarm.
Okay, thank you.
Yeah.
Next question is, are there any studies for patients affected by fatigue after 6 years? For example, 10
Yeah.
to 15 years out. I'm interested to learn if fatigue improves.
Can you restate the last part of that question?
I'm interested to learn if fatigue improves.
Yeah, that's a really great question. So I think generally, I have not seen studies that look at the long-term effects of fatigue really in any cancer 10 or 15 years out. I could certainly go and dig, and I didn't see any in CAR T cell, but we are currently running a study right now. I think I'd mentioned it in radiation oncology at Perelman at Penn, where that is our goal. So stay tuned. But I don't think that data exists, although it should exist. But oftentimes fatigue is, we stop thinking, not we, but researchers, all of it, we stop thinking about it after treatment has ended, but that's slowly shifting. So we're going to have some 3-year data coming soon, so look for that publication.
Okay. One of our listeners asked if you could repeat the name of the app to track the energy that you recommended.
Yeah, it's called the Visible app, Visible, Visible. I will say the patients that have used it have really liked it. You have the option of getting the polar armband with it, and it does. I think it costs a little bit of money, but if you're able to do it, the patients again that I've worked with have found it useful.
Okay. Next question is it possible to ever get back the same level of energy after your transplant?
Yeah, that's a really great question. I think it really depends. I try to encourage the patients I work with to think about, work through some of the understandable feelings about the role changes and finding a way to still maintain doing the things you enjoy doing, but it might look different, which I know isn't the answer that people often want and that I want to give, but I think it really depends. It does seem like in CAR T, based on the literature, there is more of a chance of coming back from the fatigue versus other diagnoses, but I think it really depends, and I think it's about, managing the fatigue and keeping your energy stores level. Again, I wish you could see me, but think of a graph with a straight line. And I think that can be helpful and remaining active and engaged in your life.
All right. The recommendation of no screens before bed, does that include TV? My wife and I like watching music videos. Is there a difference between TV and computers and that light and impact on your sleep?
Yeah, that's a really, really good question. What I tell people is it depends on where you're doing your screen time and the type of screen time you're engaging in. So I think screen time can be fine if you're not doing it in bed. The rationale for this is if you've ever heard of Pavlov's dogs, right? He paired food with a bell, and over time, the cue for the bell was all that the dogs needed to salivate. They didn't need to see the food. Humans make the same kinds of associations all the time, and we do it with bed too. So if the bed becomes paired with wakefulness and you're predisposed to insomnia, like in a stressful situation, like being diagnosed with cancer or having CAR T cell therapy, you will be more likely to be awake in bed. So if you want to watch music videos, which I think sounds awesome as an avid music lover, that's totally fine. Just do so in another room. If you don't have what we call circadian rhythm disorders, I know there's been a lot about blue light. That's somebody who's like a night owl or is up really early in the morning. Think of our night shift workers, right? A little bit of light isn't going to hurt you. I will, though, add, and I've been adding this to conversations with patients, is that just be mindful of the content that you're taking in at night. Like trying to limit, like my kids call it doom scrolling, watching things that are going to make you anxious. Those types of things can make you feel more like anxious and aroused. So again, music videos sound lovely, and if you're doing it in another room, not in bed, I think that's totally fine.
All right, next question. What are your thoughts on Ambien-type medications when you tried CBT, sleep studies, and are seeing a sleep hygiene specialist, and nothing else seems to work?
Yeah. So I'm not a prescriber, so any information I provide on medication is solely from the research and what I've seen anecdotally. What I will say is it's really up to you and your prescriber. If the medication is working for you and you're not having side effects, it's probably fine. I'm certainly not anti-medication. I think sometimes those medications, the Ambiens, the class of drugs is called a BZRA. They can cause some daytime sleepiness, or they don't always work for long periods of time. They're often best used in short-term situations, but if you find that it's working for you and your prescriber agrees, I don't really take issue with them.
Is a morning cup of coffee helpful or harmful in the overall fatigue cycle?
Yeah, that's a great question. So again, I think I was saying this with naps, that in the kind of zeitgeist, it's like no napping, no coffee. These things are bad for sleep. I think everything in moderation. I don't think having a normal cup of coffee in the morning is going to impact your sleep too much. The half-life of coffee it depends on your metabolism, but let's say somewhere around 4 hours. So I think a cup of coffee in the morning is fine. I even recommended the nappuccino if you're already a coffee drinker, a little like 4 to 8 ounce cup of coffee before you lay down. Testing that out. If you find it impacts your sleep, don't do it. But I think coffee can be helpful, give you that little boost. It's the similar kind of mechanism I was talking about, stimulant medications that have been used in fatigue. It's a similar kind of rationale to if your doctor were to prescribe you something like modafinil, which is a stimulant for cancer-related fatigue. I think it's fine.
Okay. A listener is asking just kind of a summary again as to what are the medications that are safe to take for fatigue?
Yeah, that's a great question too. So again, just want to reiterate, I'm not a prescriber, but what we've seen in the literature is they've tried modafinil, which is a stimulant. They've tried, there's been some work with corticosteroids. Again, the effects aren't, it's not going to get rid of your fatigue. I think at best it takes the edge off, which isn't a bad thing, especially during treatment. I think there's also been some trials with antidepressants, like drugs like Wellbutrin. These are all options that you could certainly bring to your treatment team. I've had mixed results. Like if I have a patient in the throes of treatment and I reach out to a doc and say, what are your thoughts on modafinil? A lot of times docs will say, no, I don't know. The research isn't that great. So it's really up to your medical team. And if you're working with like palliative care, they often know a lot about these drugs and what may or may not work for you.
I had R-CHOP chemo before CAR T therapy, and CAR T definitely caused more extreme fatigue, which has improved over the 2 years since my treatment. Why is fatigue so persistent?
Oh, goodness. That is a wonderful question, something I think about from the moment I wake up till I go to bed. I am not sure. There are some hypotheses that have been proffered. One of them, I think there's been some animal work in this arena, but it's very new and preliminary, is that when you have cancer or really anything that causes your immune system to go into overdrive, you could think about long COVID, you could think about, even something like chronic fatigue syndrome. Think of it like a light switch. So your immune system goes on and there's no dimmer. And because of this, there's some neurobiological effects to the brain, and it causes the fatigue to be virulent and persistent. This is just a hypothesis. We aren't entirely sure, but we are working to figure it out. But it's why the fatigue package that I was talking about, like bright light and making sure you have good sleep health and activity pacing, these things are important because they not only take the edge off, but they keep the fatigue in status. So it's not getting worse. Again, think of the pain analogy. We're not going to take our pain med once the pain is at a 10. We want to keep engaging in these behaviors to maintain quality of life.
Okay. Have you seen any trials with Vyvanse, Vyvanse? I took the brain version for 2024 and found it helped some days, not all, but found the generic versions didn't help at all.
Yeah, I can't speak to the generic versus label, on-label versions, but I haven't, somebody brought this up to me the other day, and I haven't read the literature, or if there is literature on the use of Vyvanse for cancer-related fatigue, but similar to modafinil, it probably will help a little bit in the way that coffee would help. It just isn't getting at the mechanism of fatigue. And, on the days where you're not feeling as good, and let's say after treatment, I'm not sure if this is the case, and you take Vyvanse, it might not have worked as well because it's not targeting the place in the brain where fatigue is emanating from, because we're not quite sure what's going on there. But I'm glad it worked for you a little bit, and now I feel even more prompted to go after this and read the literature because somebody else brought it up to me as well.
Caffeine has never impacted me. It doesn't work for waking me up or helping me stay awake. Would Nappuccino work for people like me?
Maybe. I think the reason why, again, it takes some of the edge off is because you're also taking a nap. So when we get really sleepy, something called sleep pressure builds, and that's driven by a chemical in our body called adenosine. And so caffeine blocks adenosine, the chemical that's building up in our body when we're sleepy. And so that's why we think it's a little bit effective, because you're knocking off some sleep pressure and then the caffeine is blocking adenosine. I would say, give it a try. Again, a reasonable amount of coffee. I'm not recommending like a Monster Energy drink, but it might help you just feel a little bit restored.
What about being outside in the morning at the bright light source? How early and for how long would be useful?
Oh, yeah. The sun is the best. I recommend a light box only because if you're in the midst of treatment or you're not feeling good or you live in an area where it's hard to get outside, like I live in a city, sometimes there isn't a place for me to always go. But sunlight at this time of year, if you live in an area where it's like good weather, it's not too hot, I would say take a walk, make sure you're wearing your sunscreen and your hat, of course. But I would say take a walk, whatever feels good to you, because you're also combining exercise, which is great, and getting yourself moving. So depends on what feels good to you. Sometimes people go out in their backyard and they sit in a chair, right, in a shady spot. But natural sunlight is the ideal situation.
All right. This will have to be our last question. We're running out of time, unfortunately. How persistent is fatigue after allogeneic bone marrow transplant compared to after CAR T cell?
That's a really, really good question. From what I was reading, I think and don't quote me on this, you can email me and I will look this up specifically. I think allogenic, the fatigue is a little bit worse, but I think the effects weren't large. Again, CAR T cell, more work needs to be done here in terms of what's happening during treatment and what's happening after treatment, and studies past 3 months would be useful. But you're more than welcome. Here, let me see if I can put this slide up, to email me and I can get you a better answer with some definitive data.
I guess we do have time for one more question. I feel that people may judge me for taking breaks if they aren't aware of my situation. What's a good way to deal with that or let people know?
Well, that is a fabulous question. This comes up a lot. So I'm not sure about your specific situation, but when I say taking breaks, number one, I think it's really dependent on your situation. So oftentimes with my patients, like if busy schedules or work or something like that, a break can even be 5 minutes. And if somebody is expressing judgment towards you, I think, if you feel safe to do it, so communicating, I think I just need a break and I'll be back at it in X amount of time. But this is a larger conversation around communicating. A lot of times I talk with folks about how in certain types of cancers, or in a lot of them, you don't always see how unwell someone's feeling on the outside, so people forget. It's not that you need to remind people at every second, but it's just saying like, hey, you know what, I'm going through this, or I just need to go take a break. Sometimes I even encourage people to go to the bathroom. Like if you're feeling super self-conscious about it, which is understandable, no one's going to follow you to the bathroom. And so just saying like, I need to go use the restroom, excusing yourself and taking 5 minutes or so, depending on how long you want the break to be. But that's a really great question, and probably I could do a whole nother lecture on role changes and communicating and feeling safe to do that. I wish I had more time.
Okay, thank you. On behalf of BMT InfoNet and our partners, I'd like to thank Dr. Muench for a very helpful presentation. And thank you, the audience, for your excellent questions. Please contact BMT InfoNet if we can help you in any way. I hope you have a great day.